The patient had symptoms consistent with chronic apical periodontitis. The radiograph shows that the distal buccal root and the palatal roots were treated, and there is a post in the palatal root. The mesiobuccal root was not treated, and there was extensive periradicular radiolucency. Periodontal pocketing revealed a lesion directly over the apex, and the bifurcation is involved. Infiltration anesthesia of lidocaine with 1 to 50,000 part epinephrine is administered. A 15C scalpel blade is used to carve the intrasulcular incision from the distal line angle of the first molar anteriorly to the base of the pontic in the first and second premolar region. A vertical relaxing incision is made anteriorly at the mesial line angle of the pontic. Reflection of the flap is started at the junction of the vertical and horizontal incision with the small end of a number 9 periosteal elevator. The flap is reflected around the mesiobuccal root that is to be removed and continues posteriorly to the mesial line angle of the second molar. The root is resected using a number 161 Lindemann bone cutting burr. The root is extracted with an elevator. The socket is cleansed, curetted, and packed with a gauze to absorb the metal filings generating during the removal of the coronal portion of the root and recontouring of the crown. The tissues are repositioned, and the flap is closed with a sling suture in the horizontal incision in the pontic area. This procedure draws the tissue under the pontic and maintains the proper contour of the tissue in its relationship to the apical portion of the pontic. The vertical incision is closed with an interrupted suture. Written post-operative instructions are provided to the patient. Appropriate antibiotics and analgesics are prescribed. The surgical site is examined. The preoperative radiograph depicts an extensive lesion around the mesiobuccal root. The postoperative radiograph shows the mesiobuccal root removed and the crown recontoured. 5 days later, the patient returned for suture removal. Good initial healing is noted. The sutures are washed with chlorhexidine and topical anesthetic is applied. The sutures are cut with number 18 iris scissors and removed with cotton pliers. Examination of the patient 1 year later revealed excellent gingival healing. There was no pain to percussion. Probing revealed minimal pocket depth along the buccal and palatal aspects. The 1 year post-operative surgical procedure radiograph shows a complete return of the normal periapical and lateral root architecture.